So good morning. We're just waiting a few moments while people are signing in, but I wanted to welcome everyone to this first ALD Connect boot camp. Today we'll be focusing on newborn screening families, non-cerebral families, families who are in that monitoring phase with boys that have been diagnosed with ALD but have not progressed to cerebral disease. So my name is Kathleen O'Sullivan Fortin. On behalf of ALD Connect, I'm so grateful that everyone is here, taking time on a Saturday to really get down to the nuts and bolts of the concerns of people in our special monitoring phase. I'm also a mom. I have a 16-year-old son who has been in this monitoring phase for over a decade. So I know I'm looking forward to today's presentations and panels. As much as I'm grateful for all our panelists, first, I just want to thank our sponsors. You know, we are so lucky at ALD Connect to have wonderful community and industry support. And in particular, Bluebird Bio has supported this effort and this boot camp. And so we're so grateful because without them, we wouldn't be able to put on all this great programming, or what I hope is great programming. This first panel is standards of care and assessments for pediatric patients with ALD. And although this is not ever intended to be a substitution for your own healthcare, medical advice, etc., we would ask that you take all this information in and then bring it back to your own clinicians and make decisions about your own health and your child's health. This morning, we will be joined, or we are already joined, by Florian Eichler. He's a pediatric and adult neurologist at Mass General in Boston. We have Molly Regelman, an endocrinologist from Montefiore Hospital in New York. We have Rini Pierpont, a neuropsychologist from the University of Minnesota. And we also have Amy Gaviglio, a genetic counselor and consultant for, and wait for it, the CDC, APHL, and Expecting Health. So take it away. I don't know if Florian wants to start first. I'll see everyone later. Thanks so much.
Great, thanks, Kathleen. And I wanted to keep this webinar really open to questions, and therefore I'm going to keep my remarks short and just describe how the landscape has changed for newborn screening and for young children over the past 10, 20 years. When I first started my clinic 20 years ago, we were often facing patients who were symptomatic and had very limited options. And now, due to newborn screening, we are in a much better situation where we can diagnose patients long before any lesions are present on MRI, long before any effects of adrenal insufficiency are present. And while we face, as many of you families are seeing this, anxiety about the future and unknowns about what will happen and could happen, we have a very good network through ALD Connect and also through all the experts that are also here on the panel that are guiding families and monitoring them in a way that I hope gives assurance and gives confidence in your child's health and well-being. What to expect, as many of you know, the boys and children with ALD develop normally. Their brains and nervous system are well formed. They attain first milestones wonderfully, but then they go into a risk period between predominantly the ages of 4 and 10, where they need monitoring with frequent brain MRIs. And I'll let Dr. Regelman speak to the monitoring for the adrenal dysfunction. So in terms of the monitoring with brain MRIs, we have obtained a consensus together with multiple centers. Dr. Fatemi at KKI took the lead on a recent paper on guidelines for MRI surveillance for children with ALD. What we currently recommend is that you get yearly MRIs until about the age of 3, and then you transition into MRIs being performed every 6 months. We do this because this is the high-risk period at which cerebral lesions can start. We also recommend that as long as your child needs anesthesia, we recommend that you use contrast and gadolinium administration at the same time. The reason we say that is because we don't want to have to come back with a second sedation in case there is a small lesion that we want to evaluate and give contrast for. All in all, most children we see with identified through newborn screening do very well in this program. Of course, the first MRIs are always a little anxiety provoking, but once children and families get to know the routine of meeting the radiology staff, meeting the anesthesia staff, and going through this procedure, my hope is that this becomes so routine, similar to a yearly dental visit that you would go through. The important thing to remember is that your child is not defined by having this gene, is not defined by having ALD, but it is simply one aspect that has led to closer scrutiny, closer monitoring. There's a certain susceptibility that warrants the kind of surveillance and care that we're providing. So I will maybe just close with a few comments about what I think is exciting and on the horizon. As many of you know, the implementation of bone marrow transplantation and also ex vivo gene therapy has given us more options in terms of early treatment. We are optimizing the various regimens of chemotherapy, of understanding what kinds of doses of cells and corrections and timing thereof in the course of the disease needs to occur. I think we're also getting better about understanding first signs and first symptoms. We're conducting at MGH a particular research study on eye tracking and visual processing in children with ALD. And I think together, all these new insights are giving us a much better understanding of how to intervene in a very targeted way, long before any symptoms emerge, so that we can treat children in a stage where they're retaining all their functions and leading a healthy life. So just in closing, most of the boys I see nowadays are reporting back from soccer camp and leading fulfilled lives. And this is very different than my clinic 15, 20 years ago, where we struggled with a lot of children being non-ambulatory, already in a situation where we couldn't help them. So I'm really excited about what's coming in the next few years. And I'll pass on to probably Molly Regelman.
Yes, I think I'm up next. I prepared just a few slides. So I'm Molly Regelman. I'm one of the pediatric endocrinologists at the Children's Hospital at Montefiore. And I think you should be able to see my slides now. I'm just trying to, I had the questions open for myself. Hold on one second. Everyone can see the slides now, I think, hopefully.
Yes.
So I'm going to go through a little bit about what we do for screening for adrenal insufficiency in those identified by newborn screening. And hopefully by the end, everyone will be able to understand why we do what we do. I'm going to skip out on talking about treatments for the purposes of this talk, but I'm happy to answer it in questions or later on today at 4. So before I go into too much detail, I do want to make sure everyone understands how adrenal insufficiency develops in ALD. So this is a picture that I stole from ALD Alliance's website. So it's important to understand what happens normally with the adrenal glands. So the adrenal glands sit on top of your kidneys, and we'll talk a lot about cortisol today, but they make a lot of other hormones. They make cortisol. When there's enough cortisol around in the body, it tells the pituitary gland to turn off making ACTH, which is the hormone that naturally turns on the adrenal gland. So this is like a closed loop system. ACTH goes up, cortisol goes up, enough cortisol around, ACTH goes down. And normally cortisol gets secreted according to the circadian rhythm. And you'll see cortisol is typically lowest at the onset of sleep, and then it slowly rises and peaks around 8 o'clock in the morning. This axis normally develops somewhere in later parts of infancy and as toddlers, depending on how well the child is sleeping. So in newborns, there's no normal sleep and wake cycle, and as a result, cortisol can be difficult to predict. Cortisol is important because cortisol helps you maintain your blood sugars, which is your fuel for your body, your heart, your brain, and it also helps keep blood pressure up so that the blood is going to vital organs, particularly at times of stress. So what happens in ALD is the very long chain fatty acids that are measured on newborn screening and are elevated, those very long chain fatty acids get accumulated into the adrenal cortex, the outside of the adrenal gland, and they disrupt the ability to make cortisol. I mentioned there are other hormones in the adrenal gland, and I don't have enough time to go into all of them today, but you should also be aware that the cortex makes androgen hormones, which are important for developing secondary sexual characteristics, things like hair development. And also the adrenal glands make mineralocorticoids, and we'll talk a little bit about that as well. So what happens in ALD is the adrenal glands stop working, and because they can't make cortisol as well, there's a lack of this negative feedback going up to the pituitary gland. And because there's not this negative feedback, the ACTH levels will go up. Okay, so it's just important to understand that for when we're doing these screening, when we go through screening tests. And what we understand from natural history studies is somewhere around 80 to 90% of boys will ultimately develop adrenal insufficiency. Cortisol deficiency develops before mineralocorticoid deficiency. And there's some boys who will never, and men who will never develop the mineralocorticoid deficiency. Mineralocorticoids are important for maintaining salt balance in the body. The earliest report of biochemical adrenal insufficiency is 5 weeks, and of symptomatic adrenal insufficiency before newborn screening, the earliest report was around 22 months, but there were biochemical reports earlier. Again, a topic for another time, but fewer than 1% of females are reported to have adrenal insufficiency, but I do want to point out there aren't a lot of data monitoring women with ALD to know that that's an exact number. And there are no biochemical markers to predict when adrenal insufficiency will develop. So the very long chain fatty acids don't predict when it will develop. So what are the signs and symptoms of adrenal insufficiency? Before newborn screening, we often, much like Dr. Eichler was just describing, most of the time patients would just present with symptoms to us. Now with newborn screening, the idea is that we're preventing these symptoms from developing. But if they're not picked up, chronically, children with adrenal insufficiency will not gain weight and they'll have poor growth. They'll often complain of abdominal pain. They won't eat as well. They often end up in gastroenterologist offices with constipation and other stomach issues. And darkening of the skin or hyperpigmentation is sort of the classic appearance, and that comes from a hormone that's a byproduct in the production of ACTH. And you'll typically see darkening in particular areas like genital areas, creases, and scars. And the back of the ear is a common place as well. In older boys and adolescents, you'll see a lack of secondary sexual characteristics or less developed. And in the rarer situations, you will see salt craving behaviors develop as well, where they're just licking salt off of pretzels and tossing them, or crackers and tossing them. Acutely, when a child becomes sick, adrenal insufficiency is life-threatening. It'll cause nausea, vomiting, belly aches. Kids will get dehydrated, they'll have low blood pressure, low blood sugar, and often present with altered mental status, meaning like they don't understand where they are. And usually this is associated with an infection or another stress, such as like anesthesia or sedation. And this is just a picture from a case report of a man with adrenal leukodystrophy and it's pointing out the darkening of the skin. So the creases in particular are darker. This is his wife, who is of the same ethnicity as he is. And you can see the knuckles are darker, nipples. You can't see the gums as well here, but gums often get very dark, and he also has darkening of the tongue. So with newborn screening, as I mentioned, the idea is that we're picking up on the adrenal insufficiency before any symptoms develop or minimal symptoms are present. And so a few years back, we developed guidelines with, I was a member of a committee with the Pediatric Endocrine Society, and we developed guidelines to try to help pediatric endocrinologists and metabolic specialists around the country approach boys with newborn screenings that were positive. And I will say a lot of this has come from just clinical experience and what we do. And generally the approach is under 1 year of age. We think that parents should be given an option either to do baseline levels, remembering and keeping in mind, again, that cortisol levels are difficult to predict in infancy because they do not have normal sleep-wake cycles or predictable secretion of ACTH and cortisol. But if it's difficult to travel, I know I grew up in a rural area where you had to drive hours to get to specialists. If it's a challenge to travel, that you can go ahead and do the stimulation test in that specific age group under 1 without having to do, without having to wait for baseline levels, because it would require an extra trip to the physician. And then after 1 year of age, our recommendation was to start doing 8 a.m. cortisol and ACTH levels. And then to start treatment as indications came up, and to do stimulation tests if something did not appear easily explained as either clearly normal or clearly abnormal. And besides, as I mentioned, the problems with predicting when cortisol and ACTH will be secreted, infants also have a couple of other things that can be really frustrating. One is that they tend to have lower cortisol levels than older children. And this has to do with babies don't have a lot of stress in life, and so they generally have lower levels, but they also tend to have lower binding proteins for the cortisol, and we measure both free and bound cortisol when we're doing blood work. The other thing is reference ranges for ACTH are not established under the age of 3, so we wanted to make sure that we gave guidance in the guidelines that we wrote for how to interpret tests. And then the last thing is when to start screening was really unclear at the beginning of newborn screening. I think the more experience that we have and the more patients that we're seeing, I think we're getting more and more comfortable with saying to parents that treatment should really start, or I'm sorry, screening should really start as soon as the diagnosis is made. And in the young kids, because it's so challenging to recognize signs and symptoms of adrenal insufficiency, probably being a little more vigilant in that younger group to look for it makes sense. And as kids get a little older, although it may come up and be it's maybe a little more common in that the toddler age group to see symptoms come up or to have it develop at that age, that symptoms are a little easier to recognize at home too. So this is the complicated algorithm that we wrote out, and it does look a little overwhelming to a parent, but to a pediatric endocrinologist, this should be relatively straightforward. And this is available for free on the web at the Journal of Clinical Endocrinology and Metabolism. And you can see that we use ACTH levels and then look at cortisol levels. And these boxes below tell us, okay, clearly abnormal levels are kind of ambiguous. You may want to consider doing a stimulation test, and then clearly abnormal levels, and you should just move to treatment. And I do want to point out that we have, as I mentioned, the more experience we get, the more we recognize that it is important that this is helping us identify babies early. And this is just one of the reports that one of my fellows and I wrote up a couple of years ago of 2 boys who were identified at young ages. And it just emphasizes the importance of the adrenal screening, getting started at an early age and getting plugged in with an endocrinologist. All right, this is my information, but it's also, my information is pretty available, and we'll pass it off to Dr. Pierpont. And again, I'll answer questions later as well.
Hi, everyone. Let me just pull up my slides. All right, let me know if you can't hear me, can't see my slides. I am Reedy Pierpont. I'm a pediatric neuropsychologist at the University of Minnesota. And today I'm going to talk about neuropsychological monitoring for ALD. I think we can all agree that ALD affects each person and each family differently. For some families, a lot of the focus in the pediatric phase may be about monitoring, like we're talking about today, trying to follow how a child is doing. And developmental and behavioral concerns may be in the forefront, as they are for many children who don't have ALD, or there may not be any concerns. Concerns may be small and fade into the background. And so this may be the case for a lot of our newborn screening families. For boys who do develop cerebral ALD, however, and go through the treatment process to preserve their brain function, developmental and behavioral concerns are often a major source of concern for families. And there can also be a lot of stress for caregivers and family members who want to best support a child who may undergo changes in function, which we are, of course, trying to avoid with careful monitoring. With newborn screening, the goal is to be able to intervene as early as possible, which provides a lot of hope that the effects of ALD on learning, school, social life, emotional health can be minimized. I'm going to talk about how neuropsychological testing can be used as a tool to measure how a child's brain is functioning and to contribute to the care and monitoring of patients with ALD, no matter how they're impacted by ALD. I'm going to cover 3 topics in this brief overview. I first want to talk about what is the purpose of these evaluations? What are we looking for in our testing and what does it tell us? I want to talk about what's involved in the neuropsychological evaluation for families who haven't had one. How long does it take and what do we do at that appointment? And then I'll talk a little bit about what kinds of conclusions and recommendations the neuropsychologists can make. So our evaluations are used to measure and quantify the effects that a disease or a treatment can have on cognition and on daily daily life functioning. And our evaluations are most effective when we can see how child performs on a test over time at regular intervals. So I'll give you an example. Imagine that we're administering a test to measure a child's speed of processing. So that's how fast they can complete a mental task. Let's imagine this red line as depicting the average score on the test, right at the 50th percentile, and the gray shading depicts the scores in the average range. Now, if we imagine a 7-year-old child takes this processing speed test and he scores below average, so he completes the task considerably more slowly or with more errors than other children his age. If this is the first time Alex has been tested, it will be difficult to interpret what that means. So if he has higher scores on other types of tests, we know that this is an area of weakness for him potentially, or if he has lower scores, this might be an area of strength. But we don't necessarily know why he's scoring below age expectations in the tests, though we can make recommendations to kind of help and support that challenge for him. If we do have repeated testing over a period of time throughout childhood, however, we might see that this child's scores are very similar across different assessments, and that might help us to really understand and conclude this is an area that's consistently been a challenge for this child. However, if this is the most recent test that seems to signal a change in his abilities, depending on the situation, it could signal an effective ALD or treatment on brain function. For example, if the onset of the lesion occurred before the time of testing. Of course, when we see a change in neuropsychological test performance, we need to be careful about how we interpret that, because there's always going to be some wiggle room in test scores. That's just the nature of variation in one administration to the next. We also want to make sure that the child has had enough sleep that day, that they're not taking any medications that could interfere with alertness, that they were cooperative when taking the test, trying their best, that sort of thing. And we also want to know if this test score reflects how the child is functioning in daily life. Is our example child typically slow to process information at home and at school, or is this not typical of the child? When we're thinking about ALD and cerebral ALD in particular, we're thinking about and looking at areas that specifically map onto function of the white matter tracts of the brain. So those are the tracts that are covered in myelin. And when myelin is lost, we want to think about how does that affect how the brain functions. So the areas that are typically impacted for individuals with more advanced cerebral ALD include processing speed. So that's because the myelin speeds up the signal between neurons. It also includes regulation of attention and behavior, because the white matter connections help different regions of the brain talk to each other. It can affect visual processing, especially if demyelination is in the posterior or back part of the brain, which is the most common kind of region to be affected after onset. And then also motor skills. So myelin also helps coordinate signals for movement. Some of these skills can be challenging to test in younger children and toddlers, but starting around age 3, we can begin to kind of more sensitively test the function of more specific regions and tracts of the brain. And on a research basis, we're also working toward using more newer computerized tests that might be more sensitive to changes in thinking and processing. So beyond kind of measuring the effects of a particular disease and treatment, we might be, neuropsychological testing is really important to inform our research on treatment outcomes and to be able to kind of compare newer therapies to standard treatments and how they do in terms of kind of preserving neuropsychological functioning. And then there's also a kind of a clinical role. So we can provide information to the care team that can sometimes help predict response to treatment, depending on how the child is functioning at the time that they are going into that treatment. We can help with recommending educational services and accommodations, we can help with recommending rehabilitation or mental health and behavioral supports. What does the visit entail? So we typically in the first visit will get a detailed developmental and medical history, including a family history. So if we see features of any neurodevelopmental disorders like attention deficit disorder or autism or any other concerns that can be seen in the general population, those tend to run in families. So if there's a family member who also has some of those neurodevelopmental and mental health issues, that's good to know. We typically get questionnaires about how children are functioning both at home and at school. So we might ask teachers and parents to fill out questionnaires. We will interview family members and then we'll engage in the testing activities and really carefully observe the child's behavior. Typically testing is a little bit longer at the initial visit as we're getting to know a family. And as children are older, they also have a better attention span and can complete more tests. So the appointment might be a bit longer, might be several hours instead of just a couple of hours. We might also take a little bit longer time if there are specific concerns. So I'm just going to show quickly
here we go.
testing toddler. So we might do
Watch what I do.
activities and ask them
Hey, you put them back.
do things that we can understand their kind of spatial
Put them
awareness,
back.
problem-solving abilities, things like that.
Right there. Good job.
An example of a fine motor examination. This is again a play-based activity. He's just putting coins into a piggy bank, and we're able to see how he uses his hands at testing fine motor skills. In children who are older, we typically do more kind of paper and pencil type tasks, look at their verbal and visual reasoning and problem solving, attention, memory, their ability to inhibit behaviors, sort of impulse control, language, fine motor skills. And as I said before, certain skills are very sensitive to change as compared to others. We also observe behavior, emotional expression. Is the child happy and curious? Are they irritable and frustrated? We look at their cooperation and ask caregivers how those areas are doing at home. So what happens after the assessment? Typically, we meet with the family and give some verbal feedback about how the child did on all the activities. And we provide a written write-up of the results, impressions, recommendations that they can share with their care team or with school or other providers. In terms of areas of recommendation, we can offer more general support and suggestions to all families, regardless of whether areas of concern arose during the assessment. So we can share our knowledge about the effects of ALD on children and families, provide detailed information about strengths and weaknesses that were identified. So that information can be used to help a child function at their best. We can connect patients with support and advocacy if they're not already connected, and other providers such as social workers. And then our report can be shared with teachers to raise awareness about ALD and how teachers and peers can be part of a child's team of supporters. Sometimes the neuropsychologist will make more targeted recommendations if areas of concern arise during the evaluation. So things like mental health counseling, social skills, supports. We can refer to prescribing providers if there are concerns about attention that are clinically significant, or about mood or anxiety or any other targets that can respond to medication if that were a concern. And then also some educational services and accommodations to really help kids who have difficulties in some area function their best at school. And I hope that overview has given you a better sense of neuropsychological evaluations and their role in the care for patients with ALD. And I'm happy to answer any questions related to this topic at the end of the panel. And we'll stop sharing.
All right, I believe I am up. Can you all hear me and see the slides? I'm gonna go with yes, since I didn't hear anything. So thank you so much for the opportunity to be here today, and we'll wrap up with my session on genetic counseling for X-linked adrenal leukodystrophy. And let's go here. So to start, I hope you will all kind of indulge me briefly with a quick biology lesson. I know it is a Saturday, and being transported back to your science class is probably not going to be the highlight of your day, but it does really help me set the groundwork for what genetic counseling can offer. So as you may or may not remember, the look, feel, and functions of our body are all coded by the material in our body called DNA. And DNA is essentially a sequence of 4 letters that is then segmented into units called genes. Just gonna check the chat really quick. And genes are the basic units of hereditary and how we pass on traits within our families. So traits can be anything from eye color to blood type to diseases like X-ALD. So the DNA and genes are all then packaged into structures called chromosomes. And chromosomes are found in nearly every cell in the body and are all housed in kind of the headquarters of the cell called the nucleus. So as you can see here, humans each have 23 pairs of chromosomes for a total of 46. These first 22 pairs are called the autosomes, whereas the X and Y chromosomes, seen down kind of in the right corner, are called our sex chromosomes because they dictate whether we will be biologically female, so we would have 2 X chromosomes, or biologically male, so we have would have an X and a Y chromosome. In X-ALD, we are, not surprisingly, based on the name, interested in the X chromosome, because this is where the gene for X-ALD, which is called ABCD1, is stored. And I want you to keep this in the back of your mind because this will become important in a bit when we talk more about how X-ALD is passed from parent to child. So first, before we get to how things are passed on, let's talk a little bit more about how we determine if someone does have X-ALD. And many of you, of course, have gone through this and are quite possibly already experts in this, but I want to give just a quick reminder. So to test for X-ALD, we often start with a blood test that looks for chemicals called very long chain fatty acids, or VLCFAs for short, and Dr. Regelman referred to this already. If VLCFAs are too high in the body, it can signal that there is a problem. And really, this is quite a good test for pointing us in the direction of X-ALD for boys. It is quite often elevated in boys with X-ALD, but it's really less of a good test, I guess, for girls. In girls who are also called female carriers, VLCFAs may or may not be elevated. Somewhere around 10 to 20% of females will not necessarily have elevated VLCFAs. So we really need to then go on to a more sensitive test, really both for males and females. And this is a genetic test, so it's going to be a blood test again, to look actually at the ABCD1 gene. Again, that's the name of the gene that causes X-ALD. And what we're doing when we're doing genetic testing is we are looking for changes in the DNA sequence. Kind of think of it as a typo, but we call them variants. Variants refer simply just to variation or a change seen in the DNA sequence. And just because we find a variant, it doesn't necessarily mean that it causes disease. So once we find a variant, we actually have to classify it into kind of 5 main categories, depending on how it may or may not impact disease. So I put these, this slide kind of shows those 5 main categories that all variants that are found in the body are classified into. So the first 2, benign or likely benign, in these cases, we really think that the variant is not really going to cause disease. And this is usually because it doesn't really change the function of the gene. So in these cases, we usually consider the testing to be negative. The bottom two, likely pathogenic or pathogenic. In these two cases, we really think that the variant is probably causing the disease. It's causing enough issues with the way the gene works that we think it likely is leading to disease. This third category, the one in red in the middle, stands for a variant of uncertain significance, or a VUS. You may have heard this with your own genetic testing. And this is really a tough category for us because with these variants, we really just can't tell for sure whether or not we think this disease or this variant does cause disease or whether it doesn't. So in these cases, we will often treat the case like it does have disease for a while and continue that management and that monitoring so that we can just be sure that we're not missing anything. So now I think that we know what chromosome the disease is on. Again, for X-ALD, it's on the X chromosome. And we know or have found a variant in the family, and we think it is causing disease. It's important for us to start thinking about how the disease is passed on and the risk to other family members, either existing family members or potential prospective children. So how a variant or disease is passed on is known as an inheritance pattern. The inheritance pattern of diseases whose genes are on the X chromosome, like X-ALD, have what we call X-linked inheritance. So there are two ways primarily that X-linked diseases might be passed on. So the first one that I'm showing here is when the mother is a carrier. So in these cases, the mother may or may not know that she is a carrier. She may or may not have any symptoms. But because she has, so she's got here, the orange is the X chromosome with the disease, and the other is, the blue is the X chromosome without the disease. So each time she has a child, she has a 50-50 chance of passing on that disease X chromosome. For boys, if she passes that on, they will have X-ALD because on their other chromosome, they have a Y, so they can't really compensate for the issue with the X chromosome. For females who get that X chromosome, again, 50-50 chance, they will be a carrier. And again, females tend to be less severely affected than males in X-linked conditions because they do have this other X that can kind of compensate for the one X that isn't working. X-ALD can also be passed on from a father who has X-ALD. In this case, the X with the variant, the disease-causing variant, is here from the father. And because fathers only pass on the Y chromosome to their boys, none of the sons would be affected. But because they always pass on the X chromosome to their girls, all daughters in this scenario would be a female carrier for X-ALD. I do want to quickly point out two unique characteristics of X-ALD that as genetic counselors, we also keep in mind. And the first is something called a genotype-phenotype relationship. So genotype means the genetics, so the underlying variants that we're seeing, and phenotype means the clinical expression of the disease. So what no genotype-phenotype relationship means is that right now we cannot tell what type of X-ALD someone will have based on looking at the variant. And this is true even within the same family. So we know that X-ALD, and you all are experts in this, is a spectrum disease. And we can really see all types of X-ALD really within the same family. So unfortunately, we just can't tell a lot about what the X-ALD will look like based on the genetics. The other thing I wanted to point out is a concept called de novo variants. So in some cases of X-ALD, a variant will essentially just kind of pop up, for lack of a better word, in the mom or dad's egg or sperm. And this is called a de novo variant. De novo just means new. In this case, the dad is not affected and the mom is not a carrier. The variant is really brand new in the affected child. Because it is a brand new variant, there really is no risk to other family members in this case. But moving on, this variant can then be passed on, just like the other two scenarios that I showed previously. So quickly, I want to show an example of how genetic counseling can help families understand risks to themselves, their future children, as well as other family members. So typically speaking, when we are seeing a family for the first time, we will start with, of course, initiating testing to confirm, and then also really start looking at who else we may need to be concerned about in the family. So here, this is an example. We were alerted to a newborn who was identified through newborn screening and through the VLCFA analysis and genetic testing was confirmed to have X-ALD. So we start then by drawing a family pedigree, and this is what one looks like. The boxes represent males, circles represent females, and anyone else that is colored in is represented as affected. So right away we can see, oh wow, we have a lot of males that are in a concerning time frame for X-ALD. So we really need to get those family members tested as quickly as possible. And what genetic counselors can do is help one, identify who else may be at risk, but they can also help coordinate the testing of these family members, even if they aren't in the same state as you. We understand as well that having that conversation with family members can be very difficult, especially if you weren't aware of X-ALD in your family before. So we can also help kind of prep and provide ways to have this conversation with family members. So you can see here with our work with the family, we tested quite a few family members and identified quite a few males who were affected, as well as female carriers, which has been very, very helpful for this family because all of these individuals can then begin that monitoring process that you heard about earlier from the first three speakers. So to end, I want to quickly illustrate that genetic counseling is really truly part of the X-ALD team. I know I saw a question in the chat box about who all is involved in, between neurology and neuropsych, genetics, genetic counseling, endocrinology. It really is a team effort. And of course, you as the family are the most important member of that team. In terms of what genetic counseling can do for families and really throughout this journey, of course, they can help in identifying the cause of disease, helping to coordinate that genetic testing. They can help interpret the genetic testing results. But we also really try to focus not only on the science, but on all of the emotions and support and resources that you need during this time, and really throughout the entirety of this journey. So again, we can help determine what other family members are at risk, as well as coordinate family testing. And just like Dr. Pierpont mentioned, we're also here to provide support and resources. So again, just understanding that at no point in this journey are you alone. So I think with that was my last slide, and I, like the others, are very happy to answer any questions you may have.
It's wonderful to see this this team of experts here, and just a big thanks to everyone. I just want to make a small clarification here that over the years we do not use the term female carriers anymore, and that has to do with our increasing awareness that women with ALD do present with neurologic symptoms related to ALD, albeit later in life than most men. So now we use the terms symptomatic or asymptomatic women or females with ALD. So thanks. Kathleen, looks like we exhausted all the questions.
I'm back. Yeah, no, if you haven't been paying attention to the chat, there's been tremendous information flowing. And so I want to thank everyone on the panel. Our time is up for right now, but I do want to say that, again, that 3 o'clock to 4 o'clock slot, some of our experts for the whole day will be coming back and will be able to answer questions. So I understand as a patient, sometimes my questions are not ready in the moment that they're discussing because I'm paying attention and taking it in. So we'll have this opportunity later on today to really parse through some of our questions. I know they tend to bubble up an hour after the webinar is done. So thank you all so much. If you're watching this live and you're going to proceed to the next link, take a few minutes, stretch, check in on the family, and then come and join us for the next hour of crucial conversations. Thank you very much, everyone.
Bye, thank you.
Thank you.